So, this particular slide shows a disc here in some of the annular rings, and it shows here what they call a fissure between the rings, and this is I forget what they call it, a certain kind of fissure, that when these fissures in the rings in this direction start communicating with fissures in the rings in this direction, then you get movement of nuclear material out from the inside of the disc and out the disc into a herniation bulging type situation. So these are called circumferential fissures, and when the circumferential fissures communicate with the radial fissures, you have herniation. Of course, this particular disc has been denuded purposely with instruments. This is not exactly the way it occurs. It occurs, these kind of things here start occurring right in here, in the posterolateral interior aspect of the disc, and work their way out. This is kind of important because there really is no nerve supply to this tissue in here. For the most part, most anatomists have not found nerve supply to the inner or middle annulus. There are some studies that show nerve supply to the outer annulus, but the thing that is important in this is that the interannulus can be have problems, and you just don't know you're having problems because there's really no afferent nerve supply here. So as disc protrusion occurs, the phases of it are not painful until it gets out in here somewhere, where either their outer annulus or the posterior longitudinal ligament becomes involved, or beyond that, of course, the dura mater of the cauda. So the impetus of that really is that you may be hurting yourself significantly, or patients may be hurting themselves significantly and not even knowing it until this kind of thing occurs. So this particular drawing out of Kapanji just shows how the disc is, this is upside down, but when you have flexion occurring like here, this is sideways. You'll have annular movement going this way, extension, it goes this way, side bending goes one way, side bending the other goes the other way, and this kind of thing actually happens until you're about 30 years old. After that, these hydrodynamics change into a modified hydrodynamic to the last decades of life, where this really reacts more like bone than it does like any kind of hydrodynamic tissue. It just gets very fibrous and non hydrodynamic. But we do have some hydrodynamics in effect as long as there is some movement here of this nucleus. And obviously into the 4th and 5th decades, that nucleus does have the capacity to come out and herniate. Now, these studies, this is a study, I think, done by Shaw, Hipson, and Jason. And they're very relevant to the McKenzie philosophy of treatment. Regardless of who did them. You have your disc space here with your intervertebral frame in here, and your posterior elements and your anterior elements. And this drawing just shows that as you get a central compression of the bodies of the vertebrae on the disc, you have an equal pressure outward in this particular part of the nucleus, or the nucleus itself. Everything gets squished out. And then if you have a posterior offset load, such as you would have with extension, then you have movement of nuclear material forward and into the anterior longitudinal ligament. So you have, as this nuclear material runs forward, it actually, these concentric rings of annulus start to get stretched in that direction. Once they get stretched more than 4% of the resting length, they start to break and get tangential lesions in them. And if they go over 4%, then they fail. But at any rate, you're getting this tangential strain, and I like to liken that to a rubber band, whereas with the disc like so, as you get the pressure pushing out, then you have this strain on these fibers going this way. So that's what we call tangential strain, and that happens in the opposite direction of the force. In other words, when you get an extension posterior offset force, you get tangential strain coming out this way, and then in the posterior part where you have the disc protrusions, you get what they call radial bulging. In other words, if the disc is like so, you have the capacity for this kind of thing to happen, where there's a slack here, and as the bodies come together here, you get this bulging coming out into the intercubital foramen. But not failure. But if you already have a bulge here, then this posterior offset strain may cause a larger bulge or may pinch this off. We feel that when a patient is acute and already has a bulge back here, if you extend them, you may increase the bulge, and if you increase the bulge by squeezing these things together here, you may create some pressure on the root that's coming out here, on the nerve root that's coming out. So that can have an effect on what you're seeing clinically when you do these exercises. And your anterior offset strain, your flexion strain, creates a radial bulge anteriorly and tangential strain posteriorly. This stretch thing that's going back here. The stretch thing that's going on back here is the bad thing, because it tends to stretch these collagen fibers beyond their capacity. When that happens, you have failure, and that failure has to do with this. When you have so much tangential strain coming out here, stretching these fibers this way and this way, because it's bulging this way, then these tend to break loose from each other and then break loose themselves, causing these radial fissures for this material to come on out into the nerve root area. So, this is a bad thing. And generally speaking, this is a good thing, except in the presence of a radial bulge that's already there. Basically speaking, extension causes the nucleus to move in an anterior fashion, and it causes interdiscal pressure to increase anteriorly. Flexion, anterior offset, causes nuclear material to move backward and causes increased pressure posteriorly. And this is basically what causes your disc failure. Now, these are studies done by Nackos, and he basically, what they did was they put pressure electrodes in a bunch of medical students' spines and measured interdiscal pressure during different postures. And that interdiscal pressure, again, what we're talking about was this pressure in here. As you get a centralized pressure here And when you get a centralized load here, you have pressure going in all directions in this, and that's what we're talking about. They did these studies and studied how much pressure there was in here during different postures. And basically what they found is the highest interdiscal pressure occurred during standing flexion, a loaded standing flexion. And they saw the least amount of pressure, of course, in the supine position, unloaded position. But as you bend forward, you have increased pressure. And when you sit, as you sit in more, the more flexion you sit in, the higher the pressure. Whereas this is even the highest, one of the highest interdiscal pressure, really, is sitting, a loaded sitting flexion. And then they did a variety of types of movements and saw what effect these movements here had on the interdiscal pressure. And they found that one of the highest pressures really was sit-ups right here. So this is something that you really want to avoid. You don't want more interdiscal pressure with discogenic problems. So this particular, the sit-up causes a lot of interdiscal pressure and can cause exacerbation of the patient's problems. So that if you're doing an exercise program for low back problems that are discogenic in nature, you certainly wouldn't want to do this. And then the lowest interdiscal pressure usually is in this position here, which we use a lot in treatment. We many times put a lumbar roll or a knee roll under patients to reduce the interdiscal pressure position. This particular drawing shows how flexion influences the interdiscal pressure during lifting. If you lift in a flexed position, here's the interdiscal pressure. If you lift in an extended position, here's the interdiscal pressure. So you have significantly less interdiscal pressure during this kind of lifting than you do in this kind of lifting. So what is the significance of all this stuff? And the significance is with discogenic problems, flexion increases tangential strain, it increases interdiscal pressure, it increases the likelihood of failure of the annulus posteriorly. And in extension postures decrease interdiscal pressure, decrease tangential strain posteriorly, and our basic rationale for using extension as a treatment modality in a discogenic problem. Okay. Now, when we examine the low back, we have to look at several different things.